So we're good, and we're going to begin again with our virtual attendees as well. So this is the last session for the afternoon, session D on analyzing outcomes data. And the moderator for this session is Dr. Claire Kalpakjian. And I'm sorry if I've said your name incorrectly. Claire is an associate professor and associate chair for research in the Department of Physical Medicine and Rehabilitation at the University of Michigan Medical School. She's a biopsychosocial scientist with a clinical background in rehabilitation psychology and 30 years of experience of research and service to diverse populations of persons with disabilities. She is the faculty co-lead of the University of Michigan PM&R Learning Health System, as we've heard a little bit about this morning. She's working collaboratively with diverse clinical teams to transform into learning communities by evaluating their current practices, engaging in consensus building around changing and standardizing practices, and selecting clinically relevant patient-reported outcome measures to complement clinical evaluation. So now I would like to welcome you, and I'm going to have a seat here.
All right. So this afternoon, our speakers are going to talk about analyzing the data that we've talked a lot about, selecting and capturing and flowing into our building data infrastructure. So I'm going to tell you a little bit about each person, and then we're going to get going. So Linda Resnik, who's first up, is a professor in the Department of Health Services Policy and Practice and a research career scientist at the Providence VA Medical Center. Dr. Resnik is a physical therapist by clinical background and is the principal investigator of 3 rehabilitation resource and training centers focused on health services and learning health system research, CoHSTAR, LeaRRn, and LEAD. At the Providence VA Medical Center, she leads the Center for Neurorestoration and Neurotechnologies focus area on restoring limb function. Her research focuses on development and evaluation of rehabilitation outcome measures, delivery and effectiveness of rehab services design, and evaluation of advanced upper limb prosthetic devices and other assistive technologies. And in her spare time, she led us in putting today's summit together. Dave Kohns, my colleague from U of M, is completed a pain medicine fellowship and a physical medicine and rehabilitation residency at the University of Michigan. His research interests are in the areas of nociplastic or widespread pain and health system approaches to the management of patients with chronic pain. And Dr. Kohns is the physician lead for the Michigan Medicine Spine Program's Learning Health System, which I told you a little bit about this morning. And Maggie Horn is an assistant professor in the Department of Orthopedic Surgery in the Division of Physical Therapy, I think, with a secondary appointment in the Department of Population Health Sciences at Duke University. She's clinically trained as a physical therapist and scientifically trained as a rehabilitation scientist and epidemiologist from the University of Florida. Her research program focuses on understanding the multifactorial experience in patients with musculoskeletal pain by examining patient, provider, and health system level outcomes. She has expertise in leveraging the electronic health records and informatic principles to undertake large-scale embedded clinical research. And bringing up the end, Allan Kozlowski is currently an independent consultant in rehabilitation services research and implementation. He received his Bachelor of Science in Physical Therapy in 1991 and his PhD in Rehab Sciences in 2010, both from the University of British Columbia. He practiced as a physical therapist and rehabilitation manager in work disability prevention before completing his doctorate in rehabilitation sciences. He completed his postdoctoral fellowship at the Center for Rehab Outcomes Research at the Rehab Institute of Chicago, now the Shirley Ryan Ability Lab, and the Center for Healthcare Studies at Northwestern University, in which he constructed individual growth models for FIM instrument scores for people with spinal cord injury and traumatic brain injuries. He also held a fixed-term faculty positions in the Department of Rehabilitation Medicine in the Icahn School of Medicine at Mount Sinai, and most recently in the Department of Epidemiology and Biostatistics at Michigan State University in the College of Medicine. In this latter position, Dr. Kozlowski also served as the Director of Outcomes Research at the John F. Butzer Center for Research and Innovation at Mary Free Bed Rehabilitation Hospital. He's authored more than 35 articles on topics, including modeling of rehab outcomes as individual trajectories of change, psychometric properties of measurement instruments, and exoskeleton-assisted walking. He's also instructed courses in longitudinal modeling, measurement clinical practice, and physical therapy clinical skills. And I am going to turn it over to Linda.
Thank you. So I have the honor of kicking off this session, giving you a pretty high-level view of different approaches to analyzing outcomes data, and then the three other speakers are going to dive deep into each of these specific topics. I know we have a mixed audience here. We have a lot of clinicians, we have clinical researchers, we have academicians, we have health systems representatives, and we have persons with lived experiences who are not researchers. So I hope that I can speak to a broad group of people, but I'll be giving this introduction and overview of analytic approaches. We've talked today about the learning health system and the cycle of the learning health system. And the most critical aspect of beginning to learn is once you understand what problems and questions are important to address is taking data generated through real-world practice and turning that data to knowledge. So that means, as we've talked about this morning, selection of data elements, collection and assembly of the data, and then analyzing the data to understand practice. The next section of the learning cycle is turning knowledge to performance, where we apply knowledge to change practice. And then finally, where we turn performance back to data, where there's collection and assembly of data to assess the impact of the changes that were made on practice. So I'm going to focus on quantitative analyses here and say that there are major categories of quantitative analyses. Descriptive analyses that tell us what happened, diagnostic analytics that tell us why did it happen, predictive analytics that will help us understand what will happen or what will likely happen, and prescriptive analytics that can help us understand how can we make something happen. So if we think about it, descriptive and diagnostic analytics are a type of hindsight where we look back on historically collected data to say what happened, who's our patient population, and who do we care for, what services do we deliver. Predictive analytics give us insight, and prescriptive analytics to give us some foresight into things that we can do that are actionable. So as I mentioned, what happened? Who's the patients that we care for? What type of care do we provide? How have our outcomes changed over time? And so you're going to be hearing some examples of descriptive and analytics and understanding why did these happen? How do our outcomes compare for certain subgroups of patients? People with certain characteristics, what are the factors associated with better or worse outcomes? Understanding why something happens requires more than a simple dashboard of basic data. Because, and I think as we mentioned this morning, we talked about some of the issues, that we treat different types of patients and patient characteristics are associated with their outcomes. So we have different case mixes. And observed differences between groups of patients or particular patients could be the results of the fact that different clinics, for example, are serving different types of patients. There also may be clustering by clinics, clustering by providers, where patients who go to the same clinic share some of their clinic characteristics. They may be from certain neighborhoods with socioeconomic factors in common. They may have referral sources in common, so there could be clustering by clinic. And there could also be selection bias in looking at any of our data. And selection bias means that patients in the real world aren't assigned to treatments at random. They're assigned for a reason. There are clinical indications for having patients treated in different ways. So these are all kinds of threats to what we would say internal validity of the kinds of analyses we do. And so there is a need to do rigorous analyses to be able to adjust for some of these types of threats. So that's a statistical lecture, and we're not going to give that, but I just want everyone to be aware that like a real rigorous solution that's valid, that's going to be based on payment, that is going to give you quality measures that are going to reward people one way or another, requires some other analytics. The predictive analytics that help us understand what will happen take a large amount of historical data and real-time data together to predict future outcomes, like the risk of adverse events like death or rehospitalization, or predict certain kind of recovery trajectories. They can be used to help patients set goals and expectations. This is how I think you're going to do at the end of treatment based on other patients like you. And they can help the clinician and support clinical decision-making. Whereas the prescriptive analytics can help us figure out how can we make something happen. And again, you need large amounts of historical data to look at treatment approaches that are most likely to be effective for an individual patient or for subgroups of patients, and using that information to develop clinical pathways and protocols. And of course, that's what a lot of us are really interested in. How do we use this data to improve our care and recommend specific actions or interventions that could possibly reduce the risk of poor outcomes for particular patients or subgroups of patients. There are many kinds of analytic methods that are used to help control for some of these threats, such as looking at analyses stratified by different levels of another factor, potential confounding factor. There is multivariate modeling approaches and propensity score approaches that can look at controlling from multiple confounders together. There are hierarchical linear models to account for clustering by patients within providers. And there are methods to control for selection biases, such as inverse probability of treatment weighting. So I think you're going to hear about almost all of these methods in the talks ahead. So I just wanted to give you a high-level view of them. That's my information, and then I'm going to pass it on.
Right, thank you all. My name's David Kohns. I'm one of the physiatrists at the University of Michigan. And if you were to tell 20-something-year-old David that he would be presenting at the APTA, he would have thought that he had reached the top of the mountain. Somewhere around the turn of the century, I graduated from physical therapy school. Again, this is truly an honor to be able to speak in this building in front of all of you. Thank you for your time. Let me ask, I know that a number of the people in the room are physical therapists or occupational therapists or somehow affiliated with rehabilitation. Just a quick show of hands. How many people got involved or got interested in physical therapy because of a personal injury? Quite a few. How many people got into rehabilitation because of a injury or a medical condition related to a family member? Okay. So quite a few. So again, the interest in serving these populations is quite personal. Now for me, how did I get into this whole concept of learning health systems? It really came out of the frustration of trying to kind of turn ones and zeros or patient encounters into ones and zeros and extracting discrete information from our existing learning health system. I'll step back even further. That for me, this all started in high school, jumping up for a rebound in basketball, blowing out my ankle, and yelling a very loud swear word in a very small high school. At about that same time, my father started a long journey with chronic back pain, and really sparked a question within my own mind. Why is it that some people get involved in rehabilitation programs and go on and do very, very well, and some people continue to struggle? And I would say that that's a question that has followed me throughout my entire career through medical school, residency, training, fellowship, and even to this day. I probably have more questions now than I even had earlier in this journey. So today, I'm going to talk a little bit about some of our experiences with our spine learning health system related to descriptive and explanatory analytics. A few disclosures of some of my funding. Some of the other disclosures, I am not a statistician. I'm not an engineer. I'm not a data analyst. Fortunately, I've got some people that are smarter than I am back in Michigan to help me out with a lot of these things and have helped to prepare some of the slides for this presentation. So the agenda for today, again, we're going to define some terms. Thank you for the introduction. Talk about data in and data out related to our own experiences. And then finally, why does this even matter? So I'll talk a little bit about terms as we just went over. Talking a little bit about descriptive analytics. This is really just a summary of our historic data. And this is basically a lot of averages, percentages, but it's pretty plain. It's just reading off the teleprompter. These are just essentially the raw numbers. It doesn't give us a lot into the hows or whys. Getting into explanatory analytics, well, this is not so much Ron Burgundy, it's a little bit more Sherlock Holmes, and where we are really talking about, why did these things happen, and gets into a little bit more fancy statistics. Descriptive analytics, again, gives us a clear picture of the past events, whereas explanatory analytics helps us understand the underlying cause and relationship. With our experiences through our own learning health system, I'm probably far more Ron Burgundy than I am Sherlock Holmes today. So we had three main learning objectives for our learning health system. One, who are our patients? Two, what are we doing for them? And then three, are they getting any better? I would say we got a pretty good handle on the first two, and we're still trying to work through the process on this third. So data in. We need to start somewhere. And all of us as clinicians are familiar with this sort of pattern of history, exam, moving on to treatments, and finally outcome. When we take a look at the data in, again, this is what basically makes up the bulk through this distillation that Claire talked about earlier today. Our team came to a consensus that we would make some modifications to our new patient intake questionnaire, the fibromyalgia survey questionnaire, the Promise 29 plus two additional questions about cognitive. And then we also made some intentional selections on how frequent we would burden the patient to respond to these. All patients get these FSQ and the Promise 29 for every visit. However, we set up within our system where they are not getting the Promise 29 any more frequent than every 6 weeks, and the fibromyalgia score no more frequent than every 3 months to try to minimize some of their burden. Now, for those patients that go on to get a procedure, they will be pushed out a patient global impression of change, and then the Promise function, interference, and pain intensity at either 2 weeks after steroid injection and 6 weeks after a radiofrequency ablation. Let me poll the audience again here. How many people in their group use Epic as their medical record? Quite a few. Anybody Cerner? Couple, and I'm sure there's a host of other, especially in the outpatient physical therapy realm, there's a lot of others. Let me take one more question. In the audience, I was looking, there's a lot of bright people. Representatives from Epic. Anybody? Don't be shy. Raise your hand if you're from Epic. No one? No? Oh, that's a shame. A real shame, because look at how many bright people from some of the finest institutions, all the knowledge that's being shared. My work in the learning health system, I've never worked so hard in my life to make another company's product better. Right? As we're sitting here in Washington, D.C., I start thinking about federal versus state and all of these kind of concepts. All of our different programs are kind of the states. I think we need some help from the federal government, because how many of us have struggled to get funding and resources for things like an engineer or data analyst and things like that to build the basic framework of a learning health system? How do we put together this data information? And the fact that we might have a system that in physical medicine and rehabilitation that doesn't quite even match up with our own neurology departments, right? Boy, wouldn't that be a nice other product that Epic could sell to us? So again, there was a comment earlier today about this EPIC PRO subcommittee. We need more than a subcommittee at EPIC. We need a full committee, I think. And if there's any way that we can get that to happen, I think it would make the lives easier for all of us. Not that we don't have our own individual state, concerns that we need to deal with. But I think that, when we take a look at spine and in my situation across the country, I think all of us could kind of get on board with a few questionnaires and dumping that into one sort of central repository. Now, I highlight here that there are some efforts through the American Academy of Physical Medicine and Rehabilitation to form a low back pain registry, but it's basically just the Promise 29 and a couple demographic issues. It doesn't get much further than that. I'm going to demonstrate some things that we've done that I think are far more useful. And boy, if those could have just been directly integrated into a medical record, think of how powerful that could be across the entire country. Just a wish. So this is just an example of our Tableau dashboard. I know it's very small here, but basically the way that we've designed this, similar to going to cars.com, if I wanted a yellow minivan with less than 20,000 miles, I could go on cars.com and I could select that. Well, we can do that exact same thing through how we've engineered and designed our Tableau. From just the patient, the feedback from our physicians and the information that we wanted on our new patient slide, this is some of the information that the patients are reporting. About 70% of the patients that walk through the door report as chronic, 14 acute. Now, almost 40% of them report some sort of major red flag, such as progressive weakness, but very rarely does that ever turn out to be a serious condition. And most of the time, more than 50%, the patient report that their cause is listed as unknown. So you can see mostly chronic, some scary red flags, but most of the time it doesn't turn out to be serious, and most time the cause is unknown. Now, some of the other things, again, a lot of them have tried medications and therapies. Look at how few have tried one of the most important interventions, especially for chronic pain, which is pain psychology. What do patients want? They've reported to us they want to discuss their treatment options, they want relief, and they want to learn how to better manage their condition. Now, giving credit to the patients, again, this is all integrated through our EPIC system, and this is pushed out previously, and they get reminders before coming in. About 75% compliance, which I think is pretty darn good. When patients come in, if they have not completed, it gets flagged at the front desk, and there's a paper chart, and later in the day, the MAs batch that information and enter it into the chart. So moving on from input from the history, let's talk a little bit about testing. We haven't done a lot with turning our exams into discrete information, but with testing, it's pretty easy. For those patients that walk through the door, about 45% get some sort of test, mostly x-rays and MRIs, about 10% get some sort of further test with a diagnostic block or an EMG. Most of those tests are done at the first visit. Now, this prompted a discussion at our recent grand rounds when I presented some of this information and thinking to myself, well, what if we were a little bit more proactive, such as a surgery where they require these imaging and everything to be done before the first visit? Wouldn't that just expedite matters? But if you kind of go into the research a little bit and find out that more testing isn't always better, and sometimes can often send patients down some downward spirals. So again, just because the data indicates that maybe we could expedite some of this care by getting their ducks in a row, I think some of those recommendations need to be proceeded with caution. The impression. This is the main reason that patients come to see a clinician or provider. What is your impression? Now, I want you to kind of think, what would be the two most important questions that you would want to know if you were seeing a pain patient? Anybody? How are you feeling? How are you functioning? Okay. Really good PT question. You know your audience. I asked two questions are probably the most important for me. And again, there's no right or wrong answer, but for me, the two questions are, is this an acute or chronic issue? And is this focal or widespread? Because we all in this room know that there's a far difference between an acute focal condition and a chronic widespread condition. Those are vastly different conditions that need to be evaluated and treated far different. So to assess part of that, we used the American College of Rheumatology FSQ, fibromyalgia survey score, which for those of you that may not be familiar with this basically gives us a 0 to 31 score. They use a cut point for do or don't meet research criteria for fibromyalgia is 13, but all of us reside somewhere on here. But again, it gives us kind of a quick single number that just gives us a general update understanding. Is this a more focal issue or is this a more widespread issue? And none of this really mentions anything about severity or even level of function. Now, why is this important? Well, there was a study done down the hall with our anesthesia colleagues that 42% of people coming in with a spine complaint met research criteria for fibromyalgia. In our department, it's about 36%. So a third of the patients coming through our door meet research criteria for fibromyalgia. So again, there's a vast difference between acute focal and chronic widespread. And you can see the provider's experience through our electronic medical record. We can get a quick heads up, and this gets auto-populated right into our note, where we can see that polysymptomatic score. In this patient's case, it was a 16 out of 31. And we see all the different demographic information or the domain information from the promise. So what this really gives us is just a heads up. Now, going through this process, we did have to make a ask of our physicians. Basically, what that was is that we're looking for what's called the the LHS box. And that's where we ask the physicians to give us duration, the side, the location, and the diagnostic category, because this is going to give us far more valuable information than just using the ICD-10. The data out. Within our dashboards, some of the interesting information was that coming into a spine clinic, I would have thought it would have been disc herniation, arthritis. The number one diagnosis that came through based on the physician's impression was actually a muscular. And again, when we take a look at the high number of patients with a widespread pain, it's not surprising. Now, when we auto-select more for low back pain, you can see that facet pain comes in a little bit higher on that list. When we tease out and add on the domains of the Promise 29, we can see that we get even more rich information. And then when we take a look even further in selecting down to those patients that have more muscular pain, we can see how some of those domains start to shift a bit. As far as treatments, most people get medications. Some people have get injections. I was surprised that we only refer to physical therapy 12%. Now, why does this matter? Again, we talked about sort of the data, knowledge, and practice. And finally, the outcomes. Again, the outcome information, the physician can track this along the visits as the patient returns every few weeks or months. We can also put this in a graph display. And why would these outcomes be so important? Well, this hit our spine program quite at home when we found out that there was a number of changes that were being made related to some of our facet-related procedures. Now, fortunately, we were already ahead of the curve because we were already collecting data that CMS demanded for pre and post outcomes. There's also been a number of issues related to studies. This was a fantastic study. It took 7 months with 7 researchers, 17 months. To come up with the information. With the LHS, they were trying to identify the degree of a centralized pain within a spine clinic. I could have done that same study in 4 months. Or in the time that it took them to get about 500 patients, I could be doing that about 2,000. So again, we can get some robust data replicating a number of these studies. This was a study that took me 6 years, 6 researchers, 3.5 years. With the LHS, I could have done this in half the time and had more than double the participants. Let's sort of go through some of this quickly. So in summary, descriptive analytics provides a clear picture of the past events. Explanatory analytics, which we are just getting into, gives us an understanding of the cause and effect relationship. LHS is an efficient, effective way to drive clinical-based research and improve quality. However, it is only as good as the data in and data out as you set up your frameworks. And LHS can guide patient encounters from history to impression, as well as quality outcomes within spine care.
There's his references. All right, thank you for being here this afternoon. I've really appreciated hearing all the presentations today, and I'll try to do a good job of integrating all those concepts into my presentation as well. Today I'm going to be talking to you about the role of patient-centered outcomes, specifically patient-reported outcome measures in predictive analytics. And I'm going to walk you through this concept, discussing 2 studies that we've done, and I will discuss the methods and some considerations with the approaches that we used, as well as the types of data that we used. Before we go much further, I want to acknowledge this data has come out of our total joint arthroplasty learning health unit at Duke. This was developed slightly during the pandemic, and we've grown over time. If you'll notice, this is an orthopedic surgery. However, we are bridging with our physical therapy folks to implement some of the things that we found, as well as share some of our lessons learned and expand our scope and our reach. So some context on the development of our arthroplasty learning health unit. So this was a health system driven initiative. So the health system came to the Division of Arthroplasty and said, hey, we are looking into entering several bundled payment programs. We want to have a group of people looking at patients with arthroplasty, particularly those with poor outcomes, being physical function, pain interference, high cost, high utilization. So we know in arthroplasty, approximately 20% of patients have quote unquote poor outcomes, which can include persistent pain, lack of improvement in physical function, and just general dissatisfaction. So the goal of, or part of the goal of the Learning Health Unit is that we want to predict some of these poor outcomes, or find the things or factors with these patients that can predict these outcomes. Part of this need was to create a multidisciplinary group. So the core members of our group include myself, physical therapist, Dr. Steve George with a background in pain and chronic pain specifically, and then our orthopedic surgeon, Dr. Volganisi. So together, our core group, we also collaborate with many, many other people that we'll talk about in just a second. Part of the beginning of our development of the LHU, which many people have talked about today, is you have to build the data infrastructure, and you have to be thoughtful about how you build the data infrastructure in order to be able to not only collect the outcomes that are of importance, but also design statistical methods to predict the outcomes of interest that we're looking at. So this is an ongoing process. So every year, every project, we add on to our data infrastructure, which currently consists of approximately 11 different relational tables that get refreshed regularly. In our surgical data set, we have about 41,000 surgical cases, and then we just developed a non-surgical osteoarthritis data set that has 54 new osteoarthritis cases. So we've been able to take not only what we've learned in arthroplasty, but then extend it to other non-operative conditions, such as OA, so hip, knee, and shoulder OA. Our end goals of the LHU, and it's never really an end goal because we've seen today with all the infographics, the learning health system is a circle. So our goal is to disseminate our findings. So that means disseminate through publications, disseminate within our health system, and disseminate at conferences just like this. We also want to be able to implement what we found back into our health system, again, to improve or identify patients who are not going to improve and intervene. And of course, the end goal is always to improve care for our patients. And by improving their outcomes, ultimately, we can do so through improving their care and their care processes. Wrong one. There we go. Click that one. So what we're going to talk about, or what I'm going to talk today about, is our analytic approaches. So again, like Dr. Resnik said, predictive analytics is the use of data to predict future trends and events. Also can be used to assess risks, predict trajectories and recoveries, and be used in goals and expectations for our patients. You can use many different types of data source for this project or for these type of analytic approaches, such as retrospectively collected data, prospective data that either comes from the clinical care setting or formal trials, and as I'm going to talk about in the study, electronic health record data as well. The two studies that I'm going to talk about today both use retrospective data. One study is survey data combined with electronic health record data, and then one is purely data collected from the electronic health record. A couple different broad categories of analytic approaches are classification, clustering, time series, or decision trees. Today, I'm going to talk about clustering models as well as classification models. So I know that we've kind of, many people have talked about this today. I'm not going to belabor the point. In the study and within our health system, PROMIS measures are routinely collected on all our orthopedic patients, not just arthroplasty patients. I love PROMIS for a variety of reasons. It's agnostic to most conditions. 50 is the mean to the US population. 10 is a standard deviation, therefore it is easily interpretable across different care settings as well as clinicians. It can be presented in many different ways, categorically as shown here. MCIDs have been created for not only different PROMIS domains, but different PROMIS domains across different health conditions as well. So the first study we're going to talk about is creating patient phenotypes using PROMIS measures. And the way we went about this is doing a cluster analysis. So in terms of phenotyping, this just basically means creating groups based on observable characteristics. In this case, it's going to be patient reported outcomes with PROMIS measures. For purposes of the presentation, I may be using phenotyping and subgrouping interchangeably. They're slightly different, but just PSA. As I mentioned earlier, PROMIS is collected across our health system within orthopedics, not just arthroplasty. For this study, we had two different cohorts of patients, both retrospective. Our first cohort, which we called our developmental cohort, consisted of approximately over 12,000 patients. Our validation cohort is just about over 4,500 patients. Our first cohort, we were able to use 8 PROMIS domains at the time. We were collecting PROMIS 57 within the health system. And then after the computer adapted testing version of PROMIS became available in our quote unquote flavor of EPIC, we were asked to reduce our domains down to 4 domains. And so that's why when we talk about this a little bit, I would like to say it was intentional, but this kind of helped us create a bit of a natural experiment about, you know, is 8 domains necessary, or can we do the same thing with 4? And we'll talk about that in a second. So for cluster analysis, again, PSA, not a card-carrying statistician, but in big overview, cluster analysis works by organizing items, or in this case, patients, into groups or clusters based on how closely associated they are on given characteristics, or conversely, how dissimilar they may be, putting them in a different cluster. This is an unsupervised learning model, so there's no response variable to pair these patients to. It's just saying how similar are these groups and how many groups are created from this data set that are reasonably similar and not too far away from that centroid. In the study, we used partitioning plots like you see here and gap statistics to determine the number of clusters to create these phenotypes or subgroups based on our PROMIS domains. So in this picture here, on the left-hand side, you can see the plot with the patients or with the cohort that had 8 domains. And then on the right-hand side, you can see on when we had 4 domains. And these, again, are the development and the validation cohorts. And the PROMIS domain importance to the cluster was determined by the misclassification rate for that membership. And so basically, the short of it is you take that domain out, and if the misclassification rate is higher, that means that that domain is more important, and conversely. So the domains that contributed the most to PROMIS subgroup membership in the development cohort were depression and anxiety. And our 4-domain group was depression. And relative to each other, and again, because there are different number of domains, the misclassification rate will be slightly different. However, you can notice that depression, physical function, and pain interference, and sleep have the same relative relationship to one another on that misclassification rate. So after the review of the gap statistics, we found that there was a 4-cluster solution model. And you can see visually that these clusters are somewhat similarly distributed to one another. So what does this mean? So we take these, again, for the non-statistician, we take all these graphs and these plots and we say, okay, well, what does that mean for me as the clinician or the patient? So if we take, remember on that slide, how to interpret PROMIS, we have those categorizations. We have our normal, our mild, our moderate, and our severe impairment. So if you look at the color coding on this table here, the very top box is going to be your 8-domain cluster analysis, and then on the bottom is going to be our 4-domain. And they basically get grouped into these 4 clusters. So normal functioning, meaning they're within normal limits on almost every category. Mild impairments, mostly normal, some mild impairments reported on some of the domains. Impaired function but not distressed means that they may have some impaired physical function, pain interference, but they're not depressed and they're not anxious. Whereas the full right-hand side, their function is impaired, they've got physical function limitations, pain is interfering with their life, and they're distressed, meaning a lower or higher than average depression and anxiety report. And so what this means is, or the end result of this clustering is we want to be able to take this information about patients that we collect routinely and say, okay, what can we do with this? And what we've done with this is we said, okay, great, they come into about these 4 groups. Now our next task within our learning health unit is what do we do with this information now that we've identified that patients are dispersed this way across their visits to orthopedics, and how do we treat particularly that right-hand column differently, or what do we need to intervene or not intervene on to help them be successful with what intervention they receive, whether it be surgical or non-surgical. So the next study that I'm going to talk about is estimating high-impact chronic pain using PROMIS measures, and this was done using classification analysis. So the clinical question we were asking was, can PROMIS measures be used to estimate high-impact chronic pain? So traditionally, high-impact chronic pain is derived from its own scale of questions that essentially ask the patient how much is pain affecting their daily life, most days, some days. And so this study was a secondary analysis from a survey data set that we had, but then we also paired with electronic health record data to get a baseline of the patients before we looked at those patients who did or did not develop high-impact chronic pain. So 24,000 patients, about half hip, half knee arthroplasty. DFA was used, and then we used ROC curves with the AOC values or AUC values to determine accuracy. And then from that, we were able to derive potential cutoff scores to say, yes, this patient is going to develop high-impact chronic pain. No, this patient isn't. So I'm going to blow through this a little bit more quickly. So out of the PROMIS measures that we collected, the PROMIS measures with the highest accuracy or the largest area under the curve were PROMIS physical function and pain interference. So using this premise, we are going to use these 2 measures to look at creating a cutoff score. So this is just another visual representation of that ROC curve. And on the left-hand side, you can see that the patients where it's on the yes column with high impact chronic pain, their PROMIS scores are 1.5 standard deviations away from the population mean. So fairly impaired or impaired significantly. So from this analysis, we were able to take cutoff scores. So again, those cutoff scores are 65 for pain interference. Pain interference, a high score is bad. So pain interference score of 65 or over is going to catch about 96% of people that are going to develop high impact chronic pain. Looking at physical function, a score of 35 or lower is worse on physical function scale, we're going to catch about 90% of people. So clinically, you can use this information or start to use this information to say, hey, I've got this patient that's presenting. They may have a few psychological comorbidities, but now we're also seeing that they are pretty impaired in physical function and pain interference. The probability of them developing high impact chronic pain, if they don't already have it or presently have it or at risk for it, may be higher given above or below this cutoff. So some take-home messages. So in this presentation, I covered how two different predictive analytic methods, clustering and classification models were used with promise measures or patient-reported outcome measures. We know from this patient-reported outcome measures can be used to predict be an outcome or predict an outcome in many patients. The methods that you choose for your predictive analytics will be based on many factors, such as the data available to you, the question you're answering, the methods will depend on the outcomes and the data available, and many other factors. The findings of predictive analytic outcomes need to be bridged with clinical care. That's the why we do what we do. We don't want to just do these analyses and go out into the ether and never be put into practice again. We want to affect change, and part of this is disseminating our findings and re-implementing our findings back into the health system, and that's why we do what we do. So.
So I get the daunting task of closing out the day after a series of phenomenal presentations. So hopefully I can do a good job of bringing it home. I've got 4 disclosures to make. The first is I need to seriously shorten my bio. The second is my affiliation with Mary Freebad recently changed. I moved from a consultant to an employee as a research scientist there as of last week. The third is if you look at my name tag, it says I'm affiliated with PCORI, and I'm as honored as I would be to do that, that's not the case. And the fourth is that I realized watching a number of the presentations earlier that I forgot to put in an organizational affiliation slide. So I'm going to do it the Michigan way. You'll see on the slide our flagship hospital pictured. Mary Freebad has 139 inpatient beds and 48 skilled nursing beds at that facility. And they run a full continuum of rehab programs. Mary Freebad also is part of a network of with 12 affiliate organizations that cover the Lower Peninsula of Michigan. They have affiliates in Chicago, Northern Indiana, and West Virginia. And our flagship hospital is located in Grand Rapids, Michigan, which is right about there. The network, so at our flagship hospital, we see about 500 stroke inpatients a year, which gives us a rather relatively large population for doing the work that I've been interested in for the bulk of my clinical and research career. So I get to round out the day talking about prescriptive analytics, which is the use of data to determine an optimal course of action. One of the things about moving to the level of prescriptive analytics is that requires attention to the key elements of every talk that you've heard come before. And if you've got problems or hurdles that weren't addressed at the instrument selection or the data collection stage, that's going to roll up into your prescriptive analytic phase. And every measurement should support decision-making in some way. One of the things that we've not done well as an industry is to give information back to support decision-making to the clinicians or the patients and families whose data we're asking them to do. And that's where prescriptive analytics can get us. The other thing that we're looking at bringing in here is personalized medicine, or personalized rehabilitation medicine. in that we ideally want to be able to tailor the care for an individual patient. But oftentimes we're only looking at group level data. And in order to do that, we need to look at individuals within the group. So what we've done is incorporated mixed effects models or hierarchical linear models in order to retain individual differences in the models, as opposed to treating individual differences as error in the model. What I'm going to talk to you about today is not about a little bit about work that we've done, but primarily on a grant application that we have under review with the Michigan Health Endowment Fund based on two pieces of work we've completed over the last few years. This proposal is for an implementation project that would allow us to plan individual post-acute care paths to identify the services that an individual patient would likely benefit from, and the sequence and timing in which they would benefit from based on an individual level predicted recovery trajectory. The logic model for this project is that we're looking at collecting data both from the patient through MyChart, specifically AMPAC self-report scores on basic mobility and daily activities domains, and also using MyChart as a data out portal to provide them with a dashboard with their predicted trajectory care path and map their observed recovery against it. And we also need to capture a lot of patient data from the EMR from other sources, and that includes 6-click scores from clinicians. That data goes into the enterprise data warehouse. From there, we have a sidetrack on which to do both the trajectory models and develop the care path algorithm, and to do our external validation work. And the data outside of things, we would have tailored dashboards for the patient and caregiver. Again, that would be provided through MyChart. A dashboard that's tailored to the case managers. Another one for clinicians, service managers, and it would sort of roll up the line for the higher level administrators. So what we're talking about when we're looking at care path planning is if we know the predicted recovery trajectory for a patient, and that's the dashed line in blue. So recovery from stroke is typically a rapid rise to a plateau, typically within 3 months or less. We should be able to estimate the point of transition from one care setting to another, and to identify which care settings are appropriate. Is inpatient rehab suitable for this patient? If so, what time frame from the transition from acute hospital to inpatient rehab? And then when would the transition from inpatient rehab to home with or without home care or outpatient rehab? Some of the things that are required for this to work are prognostic accuracy, which requires a sample that represents the target population. And pretty much every prognostic model that I've looked at for stroke that's research-based does not get us a representative sample. They either have explicit sampling bias, selection bias, because that was written into their eligibility criteria, or there's an implicit selection bias because people with more severe strokes don't enroll in studies. They've got too much going on and they're not going to do it. And that happened with our prospective stroke study, which I'll talk about in a moment. The next is sound practice and model building. And then the third is sound, excuse me, external validation process to ensure that your models are getting better as you iterate them. So this is a couple of slides from a study that we published last year, which describes our prototype or our proof of concept model. So you'll see on the top chart on the right, a spaghetti plot with the recovery patterns for 115 patients that we enrolled in the study. The blue segment represents the acute care and inpatient AMPAC basic mobility scores. The red segments of the trajectory represents the post-discharge patient-reported outcomes. And with that chart, you'll notice that there's variability in the baseline and the magnitude of plateau. And there's almost certainly some variability in the rate of recovery or the rate at which people transition from one to the other. In our model, we were only able to fit random effects on the baseline and the magnitude of the plateau or the asymptote to plateau because of the small sample size. We didn't have enough power to fit individual variability on the rate. So you'll see that the curves all transition in parallel. If we had been able to fit the random effects on the rate, you'd see people hit their plateaus at different times. The other thing that's missing from this slide, again, is representation of the people with more severe stroke and sequelae of stroke. So that bottom part of the curve is really sparse. And for an inpatient rehab population, there should be more lines in there. The second piece of work that we used for the basis for this proposal is a care navigation study following a stroke where we used AMPAC basic mobility routinely to follow up patients. And, so we've got almost 900 patients represented over 2 years. And what we represented here was that we can get pretty good follow-up. We had just under 50% at 90 days. And, if we fit a linear model to their data, we see a gradual uptick in their recovery post-discharge. That represents the post-discharge to 90-day phase with about an average 5-point improvement in their AMPAC scores over the 90 days post-discharge. Talked about learning health. So we're doing this under a learning health system framework, looking at a number of stakeholders, starting with patients and caregivers. We want their input into how this will work and how it will look. Clinicians, service from across the post-acute care service continuum, administrative people, and IT people in contributing into how this is implemented and built. We're looking at running this through 2 learning health cycles. So we'll have during this 2-year study period, at least 2 iterations of the trajectory model and the care path. And we anticipate getting about 1,000 patients into our model by the end. And then post program, if things go well, we'll be taking it out to our network so that we can accrue patients to improve the models even faster. So in terms of the care path algorithm, we're looking at pre-planning the post-acute care path based on the predicted recovery and the early observed recovery, and then adjust it based on clinical judgment, service logistics, or changes in the observed recovery. And if you can do that for each patient, you can aggregate those timelines and provide the service managers with a predicted census of what to expect for patients coming into their service in the near future. So if we look at 2 patients that have a similar baseline AMPAC T-scores, this one had a very rapid rise to recovery with a plateau somewhere between 3 and 4 weeks. And I've marked that 40 as a significant point because a T-score of 39 has been associated with discharge home from acute care. So it's sort of a key informational point in terms of discharge planning. If we were to plan that patient's care path, this patient might not need inpatient rehab because they've got such a fast and full recovery predicted. But but this patient was in inpatient rehab. We might be able to get this person from acute care hospital to maybe day rehabilitation instead of inpatient rehab if there's no medical necessity. And followed by some outpatient care, and they're probably going to be fine. This patient, who started at a similar level, is predicted to have a slower and lower recovery. And this might be your ideal inpatient rehab patient. With a predicted plateau at about 9 weeks, I think it is, 8 or 9 weeks. Oh, sorry, 6 weeks. So in this case, we might be looking at an IRF stay followed by home health. And then in terms of a patient dashboard, they would see similar things and we'd be able to map their recovery against it. If a patient is leading the curve, you might be able to accelerate their plan. If they're lagging the curve, you can push back their discharge date. Or if they're seriously lagging the curve, you might need to completely revise the discharge plan. In terms of clinicians, we're looking at a similar view, except the clinician we think should be able to aggregate their patient outcomes. And in this case, inpatient clinicians could see their patient's actual final outcome, which is something that they currently can't do. If we look at the program manager, they might have a similar view, but they can look at all of their clinicians, identify those who are the strong clinicians, and they become the clinical leaders, and identify the people who are weaker, and do some additional training with them. We're looking at this again as a learning health system implementation. So we're looking at developing knowledge products and in terms of the trajectory models and care path algorithm, engaging a broad range of stakeholders from the organization, and using an iterative cycle to develop and improve each of those products and to guide the implementation. And again, it's a project that's under review. And if it doesn't get funded, I'd like to talk to my newly found PCORI colleagues and see if we can come up with something. Thank you.